My name is Veronique Benamou. I'm an associate professor at McGill University, and I was former uh, director of periodontology at the university. I would like to discuss for the next 60 minutes or so this concept of minimally invasive periodontal therapy, which has been something which has been applied in my practice quite consistently over the last, I would say, 5, 6 years, and which is growing as the technology allows me to polish this technique. But to start, let's go back to what the etiologic factors of periodontal diseases are. Periodontal disease is primarily caused by pathogens, by biofilms, and not so much by, as what we thought in the past, the presence of calculus on the root surface. Although calculus plays a role as a contributing factor, it isn't the prime etiological factor. The only way that it actually contributes is because it's got tremendous plaque retentive characteristics. And another thing which is very, very important and which has become known over the last, I would say, 5 to 6 years, is that the presence of an inflammatory reaction caused by the presence of bacteria is actually responsible for the damages in the periodontium. In other words, the bacteria is present, it does not itself cause the disease, but the presence of bacteria induces an inflammatory reaction, and this very inflammatory reaction is what tends to cause structural damages to the periodontal tissues, the ligaments, the bone, and so on. Which means that we are starting to look more at the control of inflammation if we need to get some resolution of disease. Another fact that we thought was really important was that bacterial endotoxins, which we knew were present, we thought were deeply embedded in the cementum, and that one had to extensively root plane, removing specifically that cementum. And we understand now that the toxins are not embedded deeply, but loosely adherent to the root surface, and therefore can be removed with a lavage or an ultrasonics, and we'll discuss that in a moment. And so the term root planing is being replaced slowly by these other terminologies such as root debridement or root detoxification, which are much more appropriate in today's time. So what are the factors that limit our outcome? We understand right now that periodontal disease can be controlled, but conventional therapy, scaling, and root planing has always given us outcome, but is fraught with limitations, and these limitations are as follow. We have, to start, access limitations. Teeth with very, very deep pockets, teeth with anatomy which is complicated, difficult to access furcas, enamel projections such as this one, root curvature and difficult access to furcation area make it all very difficult to ensure that we actually debride or detoxify these root surfaces. Another problem, of course, is the lack of vision or lack of visual access in order to see what's going on at the depth of a 10, 12, 15 millimeter pocket is almost impossible up until now without lifting a flap. And then there is the time of treatment, which is allotted. Often I discuss extensive treatment, debridement, and then when people ask me, well, how long does it really take? And when my answer is it can take 10 to 15 minutes per tooth, well, people usually raise an eyebrow and say, well, I don't spend that long. So clearly we need to understand that time is essential. We need quite a bit of it. And then there's, of course, what we don't like to talk about, but we need to talk about, is the aptitude of the clinician. This is, for example, a case where the patient had been seen maybe a few weeks prior by his referring dentist, and the patient claims that he had a number of appointments of scaling and root planing. Now you can see that when the flap was raised, there is a tremendous amount of residual calculus there. Clearly the aptitude of that particular clinician was not ideal. And then, of course, there is the type of instrumentation that you use. It is important to keep up to date, and I would like to discuss that today in terms of what we should be using in our daily practices to get results that can be expected. If we look at the literature and studies, and this was an article which was published in the Annals of Periodontology a while back in 1996, and it was essentially a publication which gathered all of the studies which compared pockets with initial probing depth of 4 to 6 millimeters, and then had some scaling and root planing done. And if we look at all these papers that were published, we will see that in average the reduction of pocket that can be expected in pocket depth 4 to 6 millimeters is on average 1.27 millimeter, which is basically all that we can expect out of these pockets, being that they're not terribly deep to start with. When you go with pockets that are 7 millimeter up to 10 millimeter, the literature tells us that the average reduction that can be expected is only 2 millimeter, which is twice as much, but not quite good enough. As we start with the 10 millimeter pocket, if you now go down 2 millimeters less, you still have an 8 millimeter pocket, and most people don't consider that success. So how can we improve that, and is surgery the only way to improve these situations? So this is what I would like to introduce, is how do we do this to improve our non-surgical outcomes? And the question that I have for you tonight is it possible to take a case like this and to non-surgically turn it into a situation like this within a 6 months period of time? And we'll try to answer this question. So the first thing we need to look at is the instrumentation that you have available to do these therapies. And are basic curettes your only treatment of choice? And if that's the case, then certainly a lot of changes must be made. If you only have curettes, or if you have some ultrasonics but not a lot of other tools available, then this minimally invasive concept is not going to be easy to implement. And with respect to reflecting current treatment modalities, we must start looking at some type of microscopy, at the very least some loops, some specific curettes and diamond files. We have to look at what's available today in the world of ultrasonics, and of course we're going to talk a little bit about various lasers that are available. The primary goal of periodontal surgery is to detoxify the root surface, so therefore to begin by removing biofilm, primarily calculus if it's there, and to create a biologically acceptable environment. And curettes is one way, but there are also other ways to achieve this, and those will be ultrasonics and lasers. And then visual access, which we know was a problem or is a problem, can be dealt with in two ways. We can either lift a large flap, and then we're going to have direct access on the root surface, or we can consider some type of enhancement of vision by microscopy in order to see the calculus and the plaque and removing it from the pathologically altered root surface. What minimally invasive treatment is something which we see a lot in dental therapy, not just in periodontal therapy, and is starting to become, on average, very much average dentist daily practice. And basically, there are innovations within the range of operative dentistry all the way through surgical treatments, which allow us to perform a type of dentistry which is far less invasive to the patient and which promotes easier care, better recovery, faster healing, and so on. In terms of minimally invasive therapy, essentially what we're looking at is enhanced motor skills with a better surgical performance, and we need to improve our visual acuity and then sometimes use various instrumentation which allow us to be more efficient and reduce errors. The other thing we need to do is we need to consider minimal tissue trauma, and this can be accomplished through smaller incisions, but of course if we do smaller incisions, then you need to see what you're doing. The surgical field will be reduced, the healing will be much faster, but you need to ensure a similar or better outcome. And then finally, when you're done, we need to have some type of very passive primary wound closure, which will again enhance healing and facilitate the post-op outcome. What is it that we really want in a minimally invasive therapy in periodontics? Well, it's basically the same type of outcomes that we're looking for in regular therapy, conventional therapy, and basically one very important factor for us is the long-term reduction of probing depth, and then an increased clinical attachment if that's possible, and if possible we would like that to exceed that is reported for traditional approaches. So in other words, if we can go from as you can see here, almost 11 millimeter pocket, and within a relatively decent period of time bring the patient down to a 3 or 4 millimeter, well, clearly the outcome is far better than the average reported in the literature. If on top of that we can accomplish this with less recession and possibly less hypersensitivity, then that's very important. All these things, of course, will lead to an increased patient acceptance. And I have found in the practice that patients will actually look you up because they have heard that you are providing them with a type of therapy which is a little bit less invasive than the conventional large flap. So let's talk about vision or visual access. Microscopy has now taken a large place in our practices. The use of a microscope, and it's quite interesting. And sometimes I say my microscope, and people look at me funny and they go, "You're not an endodontist. Why is it you have a microscope?" Well, as far as I understand, if I'm going to be treating pockets that are 10 or 12 or 13 millimeter pockets, I definitely need to be able to see what I'm doing. And I need to focus. So at the minimal, what you need is some fairly powerful loops, and if possible, you would like to bring in some illumination, you would like to bring in some serious magnification, possibly even with a perioscope if that's available, although that takes quite a bit of a learning curve. In the practice, we use primarily loops or a microscope. The use of the microscope or the endoscope will allow you to see things that you actually never knew were even there. And as you can see here, there is right at the very base of that defect the presence of some calculus, which is really difficult to go and feel and know that you have removed. First of all, know that it's there, and then know that you have removed it. So if you can see what you're doing, then therapy is definitely less invasive, a little shorter in time, and minimizes the healing process of the patient with clearly a better outcome. If you take a look here, for example, this is basically what I would see. This would be a root with calculus as opposed to the same very root free of calculus, and it's very, very difficult to see this with the naked eye, whereas with the calculus it becomes very obvious. It's interesting that I have been a periodontist for 25 years, and when I started working with the microscope, the first thing that came into my mind is, oh my God, how did I ever do this without it? Now, the next thing that we talked about is the presence or the access to some area-specific curettes. The age of having one or two curettes in your office is gone. There are now a lot of curettes available out there, and the ones that I favor are actually some very, very specific area curettes, such as these Mini 5 or Micro Mini 5, and basically what these are curettes which are similar to the conventional Gracie curettes, but where the terminal shank is longer and where the actual blade of the instrument is much, much smaller, allowing us better access to those particular areas that you know you want to reach. There are also available some diamond files, and there are available some small curettes to access frication area and whatnot. And then if you compare here on a visual model, a mini and a micro mini curette, you can see that the shape of the instrument is similar, but the size of the blade is much smaller, which means that when you are now going to go into that very, very deep pocket, you can actually control where the tip of your instrument will be, and you can target specifically that residual calculus. Diamond files are really, really handy, especially in posterior area, in frication areas, which are difficult to reach. These are essentially the size of a periodontal probe, but they are coated with a fine diamond dust, and what this allows you to do is it allows you to really smooth out the root surfaces and to make sure that you have now gotten a surface which is completely detoxified. So these are interesting, but they are certainly not our prime tool. These to me are finishing tools. But what's more important in today's practice is the ability to have access to some type of ultrasonic scalers, and maybe I can shed some light through the different types of ultrasonics that are available out there, and the one that I particularly prefer. So when we talk about ultrasonics, the age of that one single bulky universal tip is gone. These tips have now been replaced by a variety of very much thinner, site-specific tips, which are basically referred to as micro ultrasonics. What these do is they allow you to get access to those areas that are difficult to reach, and are much more efficient and much less operator fatigue. So it's an important tool to have. What you have to understand is that the vibration of the insert is defined by the frequency and the amplitude, and these are things that you want to control on your machines. So it's interesting, it's important rather that when you get a certain machine that you have the ability to control at least the power and the frequency that's going to come out, so that you understand what happens on that root surface. There are two types of ultrasonics. There are those that we call basically magnetostrictive, and these are instruments that work by the creation of a magnetic field. Essentially, the electricity goes through this nickel blade, and there will be a magnetic field that will be developed, and that will be transformed into vibrations of the insert. The vibrations at the tip of the insert are a little bit scattered, and we will see in a moment in a video what happens on the root surface. The second type of ultrasonic that you have available out on the market now are what we call piezoelectric. Piezoelectric is very, very popular in Europe. It's popular in Canada, starting to be a little more popular in the United States. What basically piezoelectric is that electricity goes through and allows these four ceramic discs to basically expand and contract and then transfer that energy into these unidirectional vibrations at the very end of the tip. And I will show you a video of that basically works. If we take a look here at this video, this is an insert of a magnetostrictive. And you can see that the movement of the tip is a little bit scattered, and essentially what it's doing is it's tapping on that root surface. If you now compare a piezoelectric, you can see that the movement of the tip is very unidirectional, and essentially what it's doing is it's not tapping the root, but going up and down, removing the bacteria and the calculus on that surface. One important thing of ultrasonics, whether you're talking about magnetostrictive or piezoelectric, which I favor, is the cavitation effect. The cavitation effect is basically turbulence around an insert, and that turbulence creates these bubbles, and these bubbles implode, and as they implode, they basically create emission of energy, and this energy is able to eliminate accretions that are well adhered to the root surface, but also this allows to detoxify the root from the endotoxins that are loosely attached onto the surface. And that activity extends up to about 0.5 millimeter from the insert. So although it's better if the insert is touching the root surface, you will get a little bit of effect beyond that. Now, one interesting thing about ultrasonics is that in the presence of blood, which you often have in a pocket which is a little deeper, the cavitation effect actually initiates a thrombogenic effect, which is a hemostatic effect, and it reduces bleeding. And so you will see that the more you actually use your ultrasonics, the better visual acuity it is, as you can actually control bleeding in the area. And this is an effect which is really positive and very effective when using ultrasonic scalers. I would say in today's practice, the utilization of these scalers will run about 80% of the time, and the next 10 or 20% will be finishing with some area-specific curettes and then going back for a final wash with the ultrasonics. And that would be pretty much the way that these treatment would happen. I prefer, and I've been preferring piezoelectrics for the largest part of my practice. If we take a look here at the way piezoelectric work, you can see here there's a transfer of electricity towards the ceramic disc, and what happens is you get an expansion and contraction of these discs, and the energy is transferred into a motion energy, which actually creates a unidirectional movement of that tip. You can see here that is a very smooth movement, and that if you combine that with some cavitation energy, you'll end up getting a very efficient machine. The beauty of these is that the water is actually dispensed and it actually reaches the very tip, so it's very efficient. You can see, for example, that irregardless the shape of the tip, and here it's a tip which looks like a curette, you can see that the water, and here for a furcation, the water reaches the very tip, and so allows us to bring that irrigation in the depth of that pocket. And so essentially a very light touch will give you the outcome that you're looking for without damage to the root surface, which you can sometimes see on a root surface from a magnetostrictive tip. Now, this is a model that I've created for a periodontal pocket, and you can see that the liquid can go all the way to the depth of that pocket, and you can see here in an actual case the ability to really get that curette, ultrasonic shaped like a curette to the very depth, and then you can also see that the water penetrates. And here I'm working with my microscope, and so if I just move the tissue around, I can actually see till the very depth. All right. So another thing I'd like to introduce, and then I will combine all these therapy and show you outcome, is the use of dental lasers. There are many lasers available on the market, and it's always an issue. People always wondering what it is that they should buy. What one has to understand, first of all, is that the prime differentiation factor between all lasers is the type of wavelength that these lasers emit. And what's important to understand is that that wavelength cannot be changed in one laser. In other words, what you decide to buy is what you get. You cannot change the wavelength of a laser. You can change a variety of other factors, but not the wavelength. The wavelength is the light as measured in nanometers, and it's the distance between two successive wave crests or troughs in a light wave. And so there are a number of lasers available currently to the dental profession. You have diode lasers, which are really popular. There are ND YAG lasers, there are erbium chromium YAG lasers, and there are ERB YAG lasers and CO2 lasers. Each one of these, you can see, has a different wavelength. They have different emission mode. Their delivery system can be different, and they each are absorbed by a different chromophore molecules which will absorb the light emitted by these lasers. The question that everyone asks is, which laser should I buy? And there really is not one answer to that. The answer to that is to find out what it is that you need your laser for, and to find out what wavelength is going to work best for you depending what you're trying to accomplish. So, do we want the laser exclusively for soft tissue? Do we want the laser to be used on roots? Do we want to use the laser on bone? Do we want to be able to decontaminate titanium without damaging implants? And basically, these are the questions that need to be asked before we decide on a laser. The effect of a laser on any tissue depends basically on the optical property of the tissue, and so each one is different. If you look at the different types of lasers available that are most popular, they are basically separated into two main categories. There are soft tissue lasers only, and these will primarily be some diodes, CO2, and ND YAGs. And you have soft and hard tissue lasers, which are primarily ERB YAG and erbium chromium YAG. The ones that I would like to introduce, because these are the ones that I have the most experience with, would be diode lasers or non-thermal diode lasers and an erbium YAG. So what we need to understand is that to be therapeutically effective and efficient, it's really important to be able to deliver the right amount of light over a period of time so that you actually get the effect that you want on the tissue, but you don't want to cause collateral damage either due to excessive heat or conduction of heat into the surrounding tissues. So when I look at this, my prime needs in periodontal therapy and also in peri-implantitis management would be to be able to remove calculus better and more efficiently and to decontaminate the root surface. I would like to get a root surface which is biocompatible with healing. I would like to also get some biomodulation of soft tissues, and there's a lot of research which we can go to, which I cannot review all within the context of this lecture. And then if I could at the same time be able to, with the same laser, decontaminate an implant surface and possibly enhance regeneration, then that would be great. So the first thing I will cover is the concept of photodynamic therapy. I have been involved with the utilization of photodynamic therapy since the late 90s. This is early 2000. This is basically a therapy which relies on the light activating a photosensitizer. What happens is when that photosensitizer gets energized by the light, there is the production of an oxygen radical which will actually kill bacterium. And it is sufficient to cause bacterial cell death. The way it works in dental photodynamic therapy, and the system that I use, is basically the use of a photosensitizer, and the one that I have the experience with is methylene blue solution with a light source, which is basically a non-thermal diode laser, and that means that the wavelength of this laser is 670 nanometer. It does not have the ability to cut, and of course, the presence of oxygen molecule in the body. The antimicrobial photodynamic reaction, which APDT stands for, is essentially described like this. You have a diode light which causes your photosensitizer to go from a ground state to an excited state, and then as that photosensitizers cannot remain in the excited state very long, there's a production of energy that is released back, and what that creates is it takes tissue oxygen, transforms it into a free radical or a singlet oxygen, and that leads to bacterial cellular toxicity. There's quite a bit of literature published in the periodontal literature, and some is not clear. Depending on the system that you use, the outcomes have been different. There is a system present in Europe which uses toluidine blue, and the problem with toluidine blue is that you have to keep it in the periodontal pocket for about 3 to 5 minutes, and because of the presence of crevicular fluid, it's quite difficult to do that. The photodynamic therapy has very high level kills. If you take a classic bacterial colony and you expose it to photodynamic therapy, what you will see is that the cells become misshapen and almost fused, and it's a mechanical kill. If, for example, you take a clinical case and you even take a case where there is quite a bit of inflammation, and you can see some purulence coming out there, the soft tissue is very inflamed, and you, even as a monotherapy, even if you just place some methylene blue into the pocket, and you can see here that you have to place quite a bit, and then expose it to this non-thermal laser for about a minute, the outcome within a week is actually pretty incredible, considering the fact that in this particular case there was no actual removal of the calculus on the root surface as of yet. And this just shows that this is quite powerful as an antimicrobial and also as an anti-inflammatory. Clearly, I am not recommending that you leave calculus on the root surface. This is simply a case that was done to see the efficacy as a monotherapy. We certainly went on treating this case after, as you will see, removing the etiological factor. But if you take a look at this young patient who is 12 years old, and Jonathan presented as with this clinical radiographical picture, and you can see that all his molars and his anterior teeth are affected in a classical case of rapidly progressive periodontitis, or formerly known as juvenile periodontitis. We look at this and you're like, okay, this young patient is very, very young and is likely to lose all his molars and probably some of his anterior teeth as well. well. So Jonathan was treated in a conventional manner, non-surgical, minimally invasive therapy. He received debridement with ultrasonics and area-specific curettes. He also received photodynamic therapy and was followed on a 3 months recall with some chlorhexidine given to him during the healing phase to allow him to improve his oral hygiene. And at 6 months, radiographically, it's really impressive what happened to Jonathan. And you can see here that there is a tremendous amount of response. The bone, it looks like it's recalcifying or actually possibly regenerating. You can see that this happened not just in one area, but it also, if you look at this area, quite extensively regeneration at 6 months. Let's look at this area here where there's a furcation involvement, and you can see the extent of the bone loss. And you can see here at 6 months that there is quite a bit of changes. So it's important. I do not use any antibiotics on this patient because the effect of the photodynamic therapy is far more effective, and this was studied by Darvaux in Seattle. The effect of these of the antimicrobial therapy is far more important than you can get in terms of antimicrobial than any antibiotic. You can see that this young patient, in fact, the story is that we didn't want to put him through surgery at first, and we had decided that we were going to take him into an operating room and treat his whole mouth at once. And we actually managed to do that after his initial therapy. And you can see that at 2 years, this is where we've taken him. So the combination at first was just photodynamic therapy, and then we followed up with some regenerative therapy, and you can see that at 2 years we have actually saved this patient's teeth, and you can see the same thing. On the upper left side, I was ready to extract this tooth, and then saw that we had at 6 months some extensive regeneration, added a little bit more with some emdogain and some enamel matrix protein and some bone grafting, and you can see the outcome. So this is not a fluke. This happens over and over, and I will be showing a number of these cases. This is again the same patient. This is another patient in her 30s with quite a bit of inflammation. You can see here the depth of the periodontal pockets. You can see the characteristics of the soft tissue. At 3 months, this patient had received debridement and antimicrobial therapy. What's interesting is to look at the quality of the soft tissue, but what's more impressive is to look at the depth of these pockets at 3 months with a minimal amount of recession and certainly a lot of healing with respect to the soft tissue. You can pay attention here to the papillas. You can see this is a tremendous difference. And to show this case is stable from 2006 to 2000, I believe 10, you can see here with the periodontal probe in place the differences, and you can recognize, of course, this case because this is the first one that I showed you, and I showed you how therapy works with photodynamics. This patient has had amazing responses with respect to soft tissues, clearly, and you can see her with here a minimal probing depth of about 3 millimeters in this area, where initially she showed up with some 5s and 9s and bleeding on probings everywhere. And again, this happened everywhere in her mouth and very, very stable. And this was without antibiotics, without surgery, strictly non-surgical therapy. And again, you can see that the effect was right through her mouth and very, very stable. Now, if we look at it radiographically, in the anterior zone, she had mostly horizontal bone loss, so clearly we're not going to see a very, very big difference. But take a look at what happened with respect to the vertical defects in the molar area. And again, remember, this is strictly non-surgical, and within a period of time, the bone seems to recalcify and regenerate. And this is throughout her mouth extensively. And even in the anterior area where she had lost quite a bit of bone, and yet the bone seemed to level off and be very, very stable. Here's another case yet, just to show you that these are not just happening because we were lucky in those particular cases. Severe chronic periodontitis, a little bit older type of patient, but with quite a bit of inflammation. And you can see how the tissues change drastically within a short period of time. Here you can see it. This is a 15 millimeter probe, so you can see the pocket is about 8-9 millimeters. And you can see her at 3 months. And then if we follow up, look on the other side, what's really interesting is as soon as we remove those etiological factors and that we use photodynamics, what's interesting is that you don't see the classic recession that you would normally see on a scaling and root planing. And you can see here that at 8 weeks, we can see her at 6 months, we can see her at 1 year, and we can see that it's very, very stable, and the soft tissue maintains its shape, and minimal amount of recession, minimal amount of hypersensitivity. And again, so this is throughout her mouth. And now if we look at her radiographs at 1 year, you can see some extensive remodeling right here around the central incisors. You can see in the premolar area that the bone is really becoming a lot denser and a lot stronger with respect to those defects that were quite extensive. You can see that I'm getting fill here of the defects on the distal of the molar, and you can see pre-op and post-op at 1 year where the bone is really becoming a little more opaque on the radiograph, and the defects are filling in. So this is very exciting, and the way that you can understand this is that by removing or reducing the bacterial load tremendously, and by the presence of this very powerful biomodulation, which is an anti-inflammatory effect, that you're allowing resolution of the disease simply by having decontaminated those root surfaces. And I'll show you a couple more cases to see that this is very consistent. There are not just 1 or 2 cases, but that you can do this repeatedly over and over again. You can see here a tremendous amount of inflammation. This would be the patient immediately post-treatment. And you can see at 2 weeks that the tissue is already healing. He presented with a very large lesion on the palate. You can see resolution, which was non-surgical at 2 weeks, and this is the patient at 1 year. And again, you can see that the probing depth is 4 millimeter minimal, and if we look again, patient's hygiene's not terrific in this situation, but we still are managing to keep him controlled. But what's really, really impressive is the fact that we're able to see that bone rebuild. Now, if you pay attention, you may see that there's a little shadow right here. And what I believe is happening is that the bone is not completely gone, and that essentially what you're doing is you're allowing healing to happen by reducing the inflammation and the bacterial load so that it can actually recalcify. Now, this is an interesting concept, because if you actually were to perform surgery on this patient, then you'd probably end up removing what's in that area, and you'd probably lose the potential for regeneration there. And then I'll finish this particular aspect of lasers with this one patient. Again, very, very severe periodontitis without any medical reasons. There was a strong family history of tooth loss and periodontitis, and this patient presented looking like this, and he had previously told that he was going to lose all his teeth and was not ready for that. We treated him again in the same manner, warning him that he was likely going to lose a number of teeth, but he responded really well to therapy, and you can see that his pocket depths reduced. The mobility that he experienced decreased tremendously to the point that he actually wrote us a note saying that he was able to eat. Now, if you look carefully at this radiograph, and then you look at him at about a year later, you will see that he's lost a tooth here and a couple of teeth here, but that everything else is still in place. But what's really, really interesting is you will see that the lesions are filling in. The teeth are very solid, and although there's tremendous amount of bone loss, you can see that the teeth are very solid. And if you focus a little bit right in this area, you can see this furcation. This is class 3. Take a look at what happens here. And then what happens 2 years down the line, where I probe this area and I cannot penetrate there. And then when he needed an implant next to that tooth, and we looked, and you can see that the bone is actually grown right into that furcation area. So I think that speaks very, very loudly for this therapy. Now, although this works really well, I cannot remove calculus from the root surface with photodynamics. So I started looking at some other adjunct, and what came up is the possibility to use a erbium YAG laser. So erbium lasers basically are a synthetic crystallite material which is doped with some rare elements, so it'll either be a neodymium or erbium. The neodymium YAG is basically the laser which is used for the classically described LANAP procedure. You cannot use a ND YAG laser on the root surface directly. It will destroy the root. But you can use it as a soft tissue laser, and it's very effective. The beauty of the YAG laser is that it is absorbed primarily by water, and that's its wavelength is 2,940 nanometers. And you can use it as a true soft and hard tissue laser. So it's doped with erbium. And it has the most FDA clearance basically because it is a truly hard and soft tissue laser. The primary chromophore is water, and that means that it is absorbed by water and also a little bit by hydroxyapatite, and there is very little collateral damage, and you'll understand why in a moment. You can cut tooth, bone, or tissue with it if you use the proper settings, but if you don't want to cut the tooth, it'll actually just remove some microns from the surface, and research has shown the possibility to remove calculus with this laser. The way it works is that the light is absorbed by the water, and it creates a huge explosion, or micro explosion in the water, and ends up giving you this look here where the light is absorbed right here, and oops, it won't do it again. Okay, sorry about that. So basically what it does is it actually removes by pulverizing the surface, it removes some molecules by breaking the molecular bond on the surface and vaporizing it. So the heat is released outwards and does not penetrate into the soft tissue. There's very, very little change in temperature on soft tissue or bone when you actually use this laser. Now you can use it to remove calculus. You can see here on a root surface, non-contact, so it's not touching the root surface, and you can see that you have the ability to actually remove calculus from this root which is sitting on some putty and without even touching the root. It's very, very efficient. If you look at it, what the effect that it has microscopically on the root surface, it allows for very extremely precise removal, and you can see that it actually only affects the outer layers by microns. So the applications are numerous because you can not only use it for removing of subgingival calculus, but you can also use it for removing of inflamed tissue or granulation tissue within the periodontal pocket. You can use it to stimulate the bone. You can use it to debride the sulcus. You can even use it for some more minimal crown lengthening. So if you take a look here at a root which was sectioned, and you can see the calculus with the microscope, and if we come on with the tip of the laser, which is like a sapphire tip, you can see that without touching, just through the water effect and the effect of the laser coming through, you are actually removing calculus from that root surface in the non-contact mode, and it's quite efficient. We look at it, and we saw this earlier, a before and an after. Now, the beauty of this, of course, is that you can see here in a use clinically, because it is about the size of a perio tip, very efficient, and then you will see within a moment that there will be some little pieces of calculus right here that are exploding all over the place and vaporizing out of the surface without damaging the tissues, without even raising a flap. And somebody's just asked me if I lay a flap, and in most of these cases I don't. You can if you'd like to, but the idea here is to keep it minimally invasive. Infarcation's very efficient as well because you don't need a contact. So the explosions will happen, and you can see here in this particular video, you can see now a tooth, and we're looking at the tooth, we're looking at the furcal area. This would be the furcal area. The roots have been sectioned off, and you will see that the erbium liag tip can come in and actually be very, very efficient at removing the calculus with the presence of some water. The red light that you see is not the laser. This is just a guiding light that actually allows you to see where you are. You can turn that off or you can leave it on. It depends on your clinical preferences. But you can see it's quite efficient at getting to areas which otherwise would be very, very difficult to do. Some people are telling me that they lost the videos. I hope it's just this one. The presentation has enormous amount of video and very heavy, so hopefully we can see here what happens. Again, you can see that on a very narrow furcation, it is feasible to remove calculus very effectively. All right, so some people are losing video and others are not. But you can see here, it's very efficient, even in an area where a curette certainly would not fit. All right, so basically what the therapy is here is, in the first place, to use the laser to decontaminate the surface. I use it in combination with ultrasonics, and I'll show you the sequence in a moment. Basically, what I would do is I would go in at first with a pass with the laser. What it does is that it actually affects the calculus. It dislodges some of it. It almost softens it a little bit, and then I'll use an ultrasonic to remove the rest more efficiently. And then one thing that can be done is removing here the internal aspect of the diseased epithelium. And then the presence of the light inside there is reflected here by these little squigglies, which is basically the penetration of light creating some biomodulation. And then we now have a blood clot, and it goes on. So I'd like to show you what this does. I'm going to move a little quicker here because I think that we only have a few more minutes. Let me move to the actual cases. Here we go. Here you go. And so this is the type of situation. Again, you can go from very deep pocket to very controlled. And you'll essentially see here that we're going to go in with the laser first. I apologize. This is okay. Here we go. First pass with the laser. And then I will continue with ultrasonics, then go back with the laser, and here you go. Continue with the ultrasonics. So if I now show you some outcome, we can look at these radiographs. We started off here with a pocket of about 9 millimeter, which extended to about this area here. And you can see that at 6 months, the probing depth will be reduced to a 3 millimeter with a complete fill of the defect. And you can see here cortication of the bone. On this particular case, which started out with a 15 millimeter pocket, within 6 months, the probing depth went to 4 millimeter. We're starting to see some calcification as well. And you can see here that the bone is starting to become a little more cortical. The probing depth is now 4 millimeter on this case. For these types of defects, and the depth, certainly very, very efficient. You can see here, case where the presence of very inflamed tissue and a 10 millimeter pocket. We can see some nice regeneration at about a year, and we go from a 10 millimeter pocket to again a 3 millimeter pocket. And here we go, November. So this was just a few weeks ago. Where we actually are maintaining this patient quite nicely. You can see here the healing at about 2 weeks. We started off with a 14 millimeter pocket, and you can see here that over a period of time that defect is filling in. And again, this is purely non-surgical therapy to end up with a little more recession in this case, but a 5 millimeter pocket, and then a 4 millimeter just a couple of weeks ago. In the posterior area, you see a significant defect with a little bit of an overhang, 11 millimeter pocket, and we can now see that what's happening at about a year is that the pocket depth is decreased down to 4. We've removed the overhang, and you can see that the defect is filling in, and you can see her again a couple of weeks later. I have been using this laser for only about a year and a half, so I can't show you cases that are a little bit longer than that. And then finalize here with some defects that are filling in quite nicely as well in the same patient at about 1 year. So basically we can summarize by saying that this type of therapy, and possibly combined with photodynamic therapy, because there's no reason to use anything in a monotherapy concept, can be very, very useful in order to treat these patients where otherwise we could only expect changes of a few millimeters. And then I've been showing you a number of cases where we go from 10, 11, 12 down to a 3, 4, 5 millimeter. Do I typically, some of the questions are, do I typically see bone regeneration with ultrasonics and hand curettes alone? And the answer is no. With hand curettes and ultrasonics